All right, welcome back. For this one, you got all three of us here to explain a very important topic, and that is, ensuring that your basic system is all right. And so that's what we're going to go into in this video. What do you guys think? You ready?
Yeah!
All right, here we go. All right, so I'd like to start with an example, and that is commissioning a treatment planning system. And as you'll see, this is going to be a bit of an unfortunate example. As we commission a TPS, we have to take a lot of data and measure things, measure outputs and so on. We have different chamber options to do that. And here's from video 16.1, you'll remember this. So in this example, this is 2004 healthcare system in Missouri. They were doing exactly this, commissioning a new treatment planning system for stereotactic radiosurgery. So they did that, took the measurements, started treatment. And over the next 5 years, they treated 152 treatments. And then a second physicist was hired. They went to training, vendor training. In the process of that, they realized that the chamber that was used for commissioning was too large. So you'll remember the issue there. You'll remember this from the previous videos. And if you have a chamber that's not the right size for small fields, you can measure in output factors that are too low. In this case, it was 50% too low. 76 patients were overdosed by more than 50%. So the purpose of this example is not to point fingers or play a what-if kind of game. We'll understand more about the theory and practice of quality and safety. Come back to this in video 30. But the point here is that a very rigorous system of QA for the treatment planning system and the delivery system as a whole is very important. So that's what we'll talk about here. So I'd like to start first with looking at external audits and the importance of those. And particularly the important one is the external audit for machine output, because that affects everything really. You'll remember back from video 18.2, we had these various ways of establishing dose and also doing a QA for that. You could do this monthly, for example, or on a daily basis. But it's important to have redundant tests in a good quality program. Remember back to the Swiss cheese model. That was the point of that, is that having multiple tests, you could better identify error, keeping it from affecting the patient. So looking at this external audit of machine output, there are various programs that you can take advantage of. Here is one from the IROC Houston group. That's Imaging Radiation Oncology Core Houston. They mail you this little block shown here. It has embedded in it an OSLD or TLD in some cases. And then you irradiate that block under standard conditions. You set up to 100 SSD here. And then you know what dose the block should receive. And they tell you what it actually receives. Here's an example of a report that you get. This is for one particular beam on one machine. And here's the ratio of expected to delivered doses in 1% here. And you can see the historical performance. It should be 1 ideally, but you'll see there's some variability over time. And if you look over all institutions, this is what you see. This is data from 2018 shared with me by Dave Falwell, who's the PI of the IROC Houston Center. You'll see that they measured over 18,000 beams in that year and measured the outputs of those beams with the system I just showed. And on average, the beams center close to 1. The output is what it should be, but you'll see that there are some outliers. And so underscoring the importance of an external audit like this. Now, there are other systems for output checks as well. There's one run by the IAEA and so on, but to my knowledge, this is the most active one in the world right now. So to talk more about treatment planning QA, I'm going to make reference to this Medical Physics Practice Guideline, number 5, on the commissioning and QA of treatment planning systems. It's probably the most definitive recommendations that we have at this point. Treatment planning systems have a lot of parameters in them. You'll remember this probably from video 12.1. Here I'm changing the source size, and that has some effect here on the beam profile. But there are many parameters that you can change. So it's important to have a handle on all these. The first recommendation in MPPG 5A is acquiring good, high-quality data for commissioning. Fortunately, we have a task group that around this, the APM Task Group 106, published in 2008. Lead author Inder Das. This is actually one of the best task groups ever written, in my opinion. Very clear, very easy to read, concrete recommendations that will help you acquire good data. So that's step number one. Then in the report, the other main point is that you need to be doing validation of what's in your treatment planning system to make sure it's giving you what you think it is. So the number one way to do that is a measurement in a phantom. Remember, a phantom is any kind of a test object where we can measure dose in. So you measure the dose in the phantom, and you see how well it agrees with the predicted dose in your treatment planning system. So there are many different ways you can do a phantom measurement. Here I'm showing just a way you would measure with a chamber. This is a farmer chamber. You could pick a smaller chamber if you wanted. You could set it up under different depths, different conditions, and you get a planned versus a measured dose at a point where the chamber is. There are other ways to do it as well. So you could have an array. Here you're doing planned versus measure on this array of many different points in the phantom, and so on. So there are many different ways to accomplish these tests. You could use film as well. So let's go through these MPPG recommendations. And I'm not going to give you every single test that the report recommends, but I'm going to hit the highlights. So first, it recommends that you should look at MLC-shaped fields, and that should include both small fields and fields off axis. So again, measured versus treatment planning system predictions. You should do measurements under different SSDs. You should measure beams that come in at oblique angles, not just straight down on a phantom. You should measure test fields with wedges, make sure those are correct. You should look at heterogeneous phantoms. So you can have a phantom that has, let's say, a low density insert that mimics lung, or a high density insert that mimics bone, and you can measure dose after those inhomogeneities. You should do IMRT QA like we talked about in the previous video, and you can do test cases from TG119, and the MPPG itself has test cases you can download, and you should do clinical plans. Then finally, importantly, this MPPG recommends that you should do end-to-end tests and external phantom-based review that we'll talk about in a minute. So here I just want to give you the links from these two reports. These should be clickable in the player. These are test suites that you can download, the CT scans. You can download them and plan them and test them out. So now let me go back to this concept of the end-to-end test or the external phantom-based review, and they're sort of related to each other, as you'll see in a minute. End-to-end test is a bit of a jargon word, but it's very important for you to understand what it is. So let me walk you through this. There are many ways to accomplish it, and here I'm just showing one particular system. This is a anthropomorphic phantom that's available from one of the vendors. There are many such systems available. So the idea here is you treat this like a real patient. So you scan it, and then eventually you'll treat it under the LINAC. But inside the phantom, in this case, is a cavity, and you can insert different objects in there. So here you'll see a CT scan, and you see a BB on this object. And so that can be used for testing localization to make sure that your whole entire system, end to end, can hit the point that you want to hit. Here's another type of example insert, plastic, and then embedded in that a little circular or spherical gray target that you can visualize. And then you can insert film between these two slices. And here's what this type of a thing might look like on imaging. You could also insert ionization chambers into these phantoms and do measurements. Here's what that looks like in a CT scan, so you can find what the dose is at that particular point. So that then overall is the end-to-end test. You simulate, you plan, you image for alignment, and then you treat, all like you would for a patient. So it's end-to-end, meaning one end of the system to the other to really validate that everything is working as it should. Okay, so now that I've talked about the end-to-end test, I think I can talk to you more intelligently about this external phantom-based review. And I'm going to talk about the example of the Iraq Houston system, phantom-based system. Here's one of the phantoms that is available. This is the head and neck phantom. If you open it up, the top pops off and you see there's a sort of an insert, and that has film and TLDs in it. I'll show you in a minute. This whole thing gets shipped to you in a box with all the equipment available and all the instructions. So the idea here then is that you do a CT simulation of this phantom, just like you do with the patient. Again, similar to the end-to-end test. And then here's what this looks like. So you can visualize here 2 PTVs, 2 different doses, and then the cord OAR. And then inside here, embedded in here, is a film in this plane right there. There's also a film perpendicular to that in another plane. And then these points here, in green, I'm showing in green, these are embedded TLDs at different points in the phantom. You can measure the dose at those points. So the idea is you irradiate this thing, you send it back, you get readouts of the film and the TLDs at IROC-H. And then, so here's a plan. Here's what the plan looks like on this phantom. And you know the exact dose at each of these points and along each of these planes where the film is according to your treatment planning system. So you treat this like a normal patient. We're going to put it on the machine, and we're going to align it and everything just like we do with a normal patient. So here I'm showing this. So this is a scan, a cone beam CT scan. We're going to talk about this more in the imaging lectures. Here you're aligning the scan with the reference scan that gives you the IGOT alignment, and then here are the shifts that you apply to line the patient up, or the phantom, and then you treat according to the treatment plan's specifications. You're all done. You unpackage this thing, send it back to IROC Houston, and they read out your results. So here's an example report for the head and neck phantom, and you see the doses from IROC-H versus the institution at each of these points where the TLDs are and whether it's acceptable or not. So IROC-H has many phantoms, not just the head and neck phantom. This slide is courtesy of Dave Falwell. Again, you can see different body sites have different phantoms available. So let me just run through one of those quickly. This is the prostate phantom, similar kind of concept. You fill this one with water actually, which makes it cheaper to ship around, not as heavy. And it comes with 2 of these inserts, one for imaging and one for dosimetry. So you put the imaging insert in, you image it, and then you get a CT scan, and then you make a plan similar to what I just showed you. And then you put now the dosimetry insert in, and then you would treat that. This is the dosimetry insert with the film and the TLDs. So at this point, I would like to share a little bit of the community experience and data around these external phantom-based validation tests. Let's look at this list from MPPG5. So it's a long list of validation tests, and at the very end is this external phantom-based review. So one might question the value of that, given that there are so many validation tests done before that. What really is the point of this external phantom-based test? So I'd like to share a story with you around that. So this was a case of commissioning a new treatment planning system, and I was asked to offer an opinion about doing this external phantom test, and I advocated that it should be done. The physics lead of the group advocated strongly that it should not be done. And the reason behind that was kind of twofold. So one, all these other validation tests had been performed, and in fact IMRT-QA had been done, so IMRT-QA should catch a problem if it was there. That's one argument. Second is that there's the perception that these phantom tests are really done in order to credential for cooperative group trials, and they're not really necessary for routine clinical operations. So I didn't really have good responses to these, but I did have the MPPG5 report, so I pulled that out, and then it's pretty hard for anybody in a leadership position to argue that they can't make a test when there's a recommendation for AAPM around it. So interesting case, because that test was done, and it actually failed pretty miserably. It took months actually to understand why that failure was there. It turned out to have to do with the modeling of the MLC leaf tips in that particular treatment planning system. and it was fixed, but had that not been done, it would not have been identified, and because of the vagaries of these various other tests, they just wouldn't have been able to identify it. So there's a real value to this. So now let me show you some more data around this to convince you even further. So as I mentioned before, the IROC group has these many various phantoms available, and they've been quite actively using them. In 2018, they shipped 625 phantoms. This is data from Dave Falwell, and you can see the breakdown of the different types of phantoms that were shipped out. So there's a lot of information now in this database, and here's some of what's coming out. So you'll see the pass rates for the various phantoms here. 87% for head and neck, 71% for the liver, 85% for the lung, 85% pass rate for the prostate phantom also, and then 77% pass rate for the spine. So all in all, there are thousands of different tests run in various clinics, and the pass rates are not nearly as close to 100% as we would like. Note also here that the criteria are not very stringent. So you've got a required agreement in order to pass of something like 7% or 4 millimeters, or maybe 5%, 5 millimeters. But theirs are not as stringent. That you need one of the TLDs to be within 7% of the predicted dose. That's not very stringent compared to some of the other tests that we've talked about in the previous videos. I'd also like to share this study published by the IROC Houston group in 2014. It shows kind of data similar to what we've just talked about. I think the crux of this can be seen from this figure. On the x-axis, it's plotting the RPC phantom results. RPC is the old name for IROC Houston. So the results of the phantom as a percentage difference between their test versus the institutional reported dose. And you see that their test varies all over the place. You get outliers out to 10% deviations from what it should be. And it's even it's not centered around 0 either, as it should be. And then on the y-axis, they're plotting what the institution reports as the IMRT QA results, the percent pass rate. So it should be 100%, and that would be along the 0 line. So what you'll see here is that the IMRT QA is not predictive at all of whether this phantom will pass or fail, really. So you can have a very poorly performing plan in terms of the phantom test results. Maybe it could be even 10% off, and yet the IMRT QA says that passes at 100%. Sobering data that underscores the importance of these tests and underscores this as one of the key validation measures as advocated by the MPPG and other groups. All right, so there you have it. With these 4 videos together, hopefully you have a pretty good overview of quality assurance. I haven't talked about everything, but I'm going to leave you with this further reading list, some references on these topics. And then let me talk a little bit about what I haven't talked about. So there are a couple things. So one, I have not talked about the QA of imaging systems, and that's important. So you've got the simulators, you've got imaging on the linear accelerator, and you have to QA those systems. I'm going to come back to that, though. I'm going to have a whole video about that, but we need to talk about imaging in general first. So I haven't gotten into that. And then I also haven't talked about specialized systems like tomotherapy or CyberKnife or some of the proton systems. So these are kind of specialized topics, and I think I'm just trying to balance the detail with the amount of time and what I have to get into here. So hopefully with the references, you can dig into more of that as needed. Okay, thank you.